And with that, I will present our first speaker, is Dr. Zak from Mass General Hospital, presenting on laparoscopic ROUX-EN-Y gastric bypass patients have an increased lifetime risk of reoperations when compared to laparoscopic sleeve gastrectomy patients.
Thank you for the opportunity to present. I have no disclosures. So to set the stage for our investigation, I must start with the premise that laparoscopic sleeve gastrectomy does not yet have a well-established long-term procedure-related morbidity profile compared to laparoscopic ROUX-EN-Y gastric bypass. There is some short-term data available, and some randomized trials, such as this one, have shown no statistically significant difference in perioperative morbidity or reoperation rates, although the follow-up here is very short, and there is some trend toward increased postoperative mortality, morbidity, and reoperation rates for ROUX-EN-Y gastric bypasses. Another randomized controlled trial seen here sort of replicates these findings and shows no difference in morbidity with outcomes at 1 month and up to 2 years post-op. Some retrospective review, though, of sample sizes that are much larger than the randomized controlled trials have been published so far, show that there might be a trend toward increased reoperation and readmission rates for gastric bypass patients. And large multi-institutional reviews of prospectively collected data from the ACS Bariatric Surgery Center Network, which has now merged with ASMBS to form the MBSA QUIP, show that at 1 year, there is higher readmission, reoperation rates for gastric bypass patients, as well as increased length of stay and 30-day morbidity. So our aim here was to compare our 6-year data on reoperations occurring after and related to laparoscopic ROUX-EN-Y gastric bypass versus laparoscopic sleeve gastrectomy at a large academic bariatric center of excellence. This was a retrospective review of all our patients undergoing these procedures between January of 2009 and September of 2014, with the primary endpoint being procedure-related reoperations. The secondary endpoint was the reasons for these returns to the operating room. We excluded patients who had open bariatric procedures, as well as patients whose index operation was performed at an outside facility, and those who went back to the operating room solely for an endoscopic intervention. We have 4 bariatric surgeons at Mass General. The laparoscopic sleeve gastrectomy is performed in a fairly uniform fashion using the interventional endoscope as a bougie. And half of the surgeons use bioabsorbable staple line reinforcement. The laparoscopic ROUX-EN-Y gastric bypass is performed in a retrocolic, retrogastric fashion by 2 of the 4 surgeons, with the others using the anticolic, antigastric approach. And the GJA anastomosis is done mostly with an interlinear stapler and a 2-layer closure. So overall, we found that 1,513 bariatric index procedures were performed. 1.7% of these were gastric bands, and these were excluded from our analysis. We had 934 gastric bypasses and 553 sleeve gastrectomy patients. The median follow-up was 45 months for the gastric bypass group and 14 months for the laparoscopic sleeve gastrectomy group. In that latter group, approximately a quarter of the patients were followed up at more than 2 years. There were no demographic differences between the patient groups. As you can see here, only 5 or less than 1% of the laparoscopic sleeve gastrectomy patients required a return to the operating room. And for the laparoscopic ROUX-EN-Y gastric bypass group, there were almost 7% of the patients who had to go back for a reoperation. This was statistically significant and conferred a relative risk of over 11 for the gastric bypass patients. There was no difference in the gender distribution for the patients who had to return to the OR. There was a difference in the BMI at the time of the first reoperation for the bypass group versus the sleeve gastrectomy group. And this can be explained by the timing of those operations, as I will show you shortly. If you look at the causes for reoperation, most of the returns to the OR after a sleeve gastrectomy were due to bleeding or hemorrhage. And this occurred early on, obviously within days of the operation. On the other hand, for the bypass patients, very few of them required return to the OR for hemorrhage. The most common reason for a reoperation in this group was a sort of vague abdominal pain, nausea, and vomiting of indeterminate cause. And oftentimes, these diagnostic laparoscopies did not reveal the reason for that pain. I just want to clarify that the numbers you see here are percentages of the total returns of the operating room, total returns to the operating room, as opposed to the percentage of the incidence of these complications. Internal hernias and adhesive bowel obstructions were responsible for 15% and 17% of the returns to the OR, respectively. Internal hernias mostly occurred through the mesocolon and the retrocolic, retrogastric bypass patients, with a small percentage happening through the Peterson's or the JJ mesenteric defect. 9.3% of the patients went back to the OR for functional obstruction, and most of these were as a result of technical mistakes where the roux limb was essentially obstructed as it exited the transverse mesocolon. Our overall leak rate was about 1%. It represented 8% of the total returns to the OR. And in this group, one patient was actually responsible for 6 of the 9 reoperations. There was only 1 leak from the original gastrojejunostomy and anastomosis. And as you can see here, incisional hernias, non-healing ulcers that failed medical management, intussusception, and the need for ERCP access represented a very small percentage of the patients who needed to go back to the operating room. The patients with non-healing ulcers and intussusception, interestingly, had the highest drop in BMI at the time of their reoperation. And so once we knew the causes for these reoperations, the timing distribution made more sense. So for the sleeve patients, all of the reoperations occurred very early on, as most of them were for hemorrhage. The distribution of the timing for gastric bypass reoperations was trimodal. So there was the first peak of patients who went back to the operating room within days to weeks for functional obstruction or hemorrhage. Then there was the second peak between 6 and 18 months. And these were the patients who went back with abdominal pain, adhesive bowel obstructions, or internal hernias. And then the last peak that occurred beyond the 2-year mark. And most of these patients had incisional hernias, ulcers that weren't healing, or intussusception. So in conclusion, sleeve gastrectomy is associated with a relatively low rate of reoperations, while patients after ROUX-EN-Y gastric bypass are at a significant long-term risk for multiple operative procedures. Most reoperations after laparoscopic sleeve gastrectomy occur early and are due to hemorrhage. And reoperations after laparoscopic ROUX-EN-Y gastric bypass have a multimodal distribution, with the majority occurring at over a year post-operatively. And although the current data shows that gastric bypass may lead to a slightly better weight loss and reduction of diabetes, this may be outweighed by the long-term morbidity of potential repeat operations in some patients. And in our opinion, the relative risk of reoperations after gastric bypass must be considered when making the initial choice for a specific bariatric procedure. Thank you. I'll take some questions.
Open for questions from the audience.
Dan Cotter from Salt Lake City. I just want to congratulate you for presenting that wonderful paper about something that I've been saying for years, that we are lying about our gastric bypass revision rate. In Salt Lake City, we've been doing this for over 30 years, and I'm constantly seeing patients at 5, 10, 15, and 20 years out from their bypass with ulcers and strictures. And it's a significant challenge. So congratulations on a fabulous paper.
Thank you for your comment.
Peter Gorecki from New York. I was curious whether we know that in many of these operations, we wrote a paper about the readmissions. For unknown reason, even among experienced surgeons, your early cases versus your late cases, somehow learning curve is still there. Whether you made any difference between, let's say, the first 200 cases versus the last 200 cases, whether there was any difference in reoperations, especially in comparable time periods.
So for the sleeve gastrectomy, there was no difference early and later on. For the gastric, as far as the gastric bypass is concerned, our group has been doing those for way longer than the retrospective duration of the study, so I can't really comment on that.
Back microphone.
Hi, Nabil Tariq, Houston. Just curious, since probably on my count, maybe a third of your reoperations were from either internal hernias or functional obstruction, whatever, all mostly because of the retrocolic limbs. Is this convincing enough for two of your surgeons to stop doing retrocolic or not?
I don't think it's a third of those operations. Our overall occurrence of the functional obstruction was about 1% out of the 7% of the return to the OR. And I can tell you that practice patterns have not changed. There may have been a learning curve over the years where the functional obstructions have happened early on in our review, but I can't comment on that with certainty.
I had a question. If I heard the numbers right, you said the median follow-up for the sleeves was 14 months and the median follow-up for the bypasses was 45 months. And the majority of your returns to the OR for the bypasses happened greater than 1 year. So do you think if you followed your sleeves out those 45 months, the numbers may look similar?
So the goal is to get to that level of data for sure. I think since we have seen the patterns of return to the OR for the sleeves being so early on, I think the chances that we're going to see a separate peak occurring very late is relatively low. And for the quarter of the patients that we have followed up beyond the 2 years, we haven't seen any reoperations late.
So do you think we should stop doing bypasses?
I do not. I think obviously their patient selection is very personal, and this is just one of the factor among a multitude that needs to be considered when making that decision.
It seems pretty clear that if your sleeve doesn't bleed, you're going to be in pretty good shape. But what were the reasons for reoperation on the non-bleeds in the sleeve group?
So the other two patients, actually, one came back to the operating room for something that was relatively unrelated to the sleeve gastrectomy itself. So one had a concurrent ventral hernia repair at the time of the operation and went back for a missed anerotomy. And the other one had a ventral hernia repair at the time of the operation, went back for a wound debridement.
Any other questions? Okay, thank you.
Thanks.